And thank Okay. Welcome, everyone, and thank you for joining us for today's Bridge Lunch Break event, Help Wanted in Healthcare Next Steps. My name is Jacqueline Garrett, Fund Development Associate at Bridge, Michigan, your source for nonprofit, nonpartisan news in Michigan. In this hour, we'll discuss Michigan's healthcare staffing crisis and hear about how organizations are mobilizing to bring in new talent into the field. This event will focus on the state of healthcare staffing in Michigan, informing listeners about healthcare career pathways, and highlighting current efforts to steer Michigan residents to these jobs with good wages. Our special guest panelists today include Brian Peters, CEO of the Michigan Health and Hospital Association, Rachel Ruddock, Director of Workforce and Health Professions Training at the Michigan Primary Care Association, and Michelle Wein, Director of Research at the Michigan Health Council. They will discuss their role in growing talent in healthcare professions. Bridge Michigan's lead health writer for Health Watch will moderate the discussion, Robin Erb. You can read the full bios of our panelists on the event page, and we'll drop a link to that page in the chat. Our conversation will begin in just a moment, and Robin will lead the discussion with our panel for about 40 to 45 minutes, and we'll then turn to your questions. Please type any questions that you have for our panelists into the chat window at any time. If you're not a panelist, please remain muted throughout today's discussion. We are recording today's conversation, and it will be posted on Bridge Michigan this week. You can subscribe to our daily or Health Watch newsletters by visiting www.bridgemi.com and click subscribe. Events like this are made possible by the support of Bridge members. If you'd like to join this membership community, we will drop a link to do so in the chat. Again, just a reminder, please stay muted throughout the conversation. I will now pass it over to Robin Erb to get this event started.
Well, thanks, Jackie. I appreciate that. Again, I'm Robin. I lead the Bridges Health Watch. I've done that for a couple of years, and I've been really thrilled this year to, I don't know if thrilled is the right word, but it's been interesting and it's been sobering writing about these healthcare worker shortages facing our state right now, because we're talking about some really difficult, big problems facing us for the next few years. And I've also been thrilled, I think that is the right word here, to talk to some of the smartest people in healthcare, including these three people that are joining us today. So let's start talking, just kind of, let's come in from the highest level. Brian, I'm going to start with you. You represent Michigan's Health Network, and we've been writing a lot. We've been hearing a lot about the shortages in nursing, but we know there are other healthcare shortages. You launched a campaign, MHA launched a campaign earlier this year to raise awareness about those other positions. And Jackie, I think we have a link, if we could share that. Brian, let's start with you. Beyond nurses, tell us about some of the other healthcare worker shortages we're facing.
Well, thank you, Robin, and good afternoon. It's really a pleasure to be able to talk about such an impactful subject. And you're exactly right. You use the word sobering, and that's a good description, because unfortunately, this is an issue that we've been grappling with for some time, and there really is not light at the end of the tunnel in the near term. We know this is a long-term challenge that we're dealing with. And so when we look at the Michigan healthcare ecosystem, we are now the state's largest employer, 570,000 jobs in healthcare. 219,000 of those are directly in our member hospitals throughout the state. And many of those are nurses, but as you said, nurses are not the only spot where we have a very significant shortage. That's both in the clinical and non-clinical arena. And so earlier this year, the Michigan Health and Hospital Association, at the direction of our board of trustees, launched a new initiative, including a website that you referenced, the mihospitalcareers.com site. And as you'll see on the site, we have job opportunities that certainly relate to the practice of medicine and care delivery, nurses, doctors, therapists, all of those activities that you would expect in a hospital setting, but also environmental services, food services, accounting and finance, human resources. The list goes on. And the reality is, because we have more and more demand for healthcare in this aging population, we continue to have a growing need for all of those individuals to join our ranks. Great news, those opportunities are here today. They're going to be here in the future. And that's a reason for young people to consider healthcare as a career option and take advantage of those training opportunities that exist in our four-year universities and community colleges.
Yeah, to that point, I was talking to an 18-year-old, a young man yesterday, and he was saying that he was interested in digital media. And I think in one of your campaigns, the pictures sweep by all the different healthcare jobs. And one of those is somebody who's running social media for the health and or for the hospital. They really are jobs that you might not normally connect to healthcare. Brian, I'm going to follow up with you before turning to Rachel and Michelle. To some extent, we know the pandemic drove people out of healthcare. We know that, but we've also known for years that we were going to face this great resignation only or retirement, because our baby boomers were hitting that 65 their 65 birthday candles. Why couldn't we do a better job of heading this off?
Well, it's a great question, and it's one that, as we look back, we wish we would have had a better pipeline in place, more programs that could train those practitioners of the future, and frankly, do a better job of shining a light on healthcare as a career path. I think we've seen for the last couple of decades now, too many of our young people that went all the way through middle school, high school, and even undergraduate years in college without ever getting a good feel for the opportunities that existed in healthcare. And that's in hindsight. I think our job now is to look at the situation we have and what can we do better going forward. I'm certainly encouraged by the fact that in this last budget cycle, we worked so closely with the community colleges and four-year universities to create funding and new programming very specific to healthcare careers. And so I think the opportunity is going to be there. We just have to really maintain our focus and do a better job going forward in that regard.
And I'm going to interrupt myself here. I should let our readers, listeners know too, viewers, I'm not sure what the word would be here, that at the end of today, we have everybody's email. We're going to follow up with an email. I'm going to send everybody a thanks. And in that email are going to be links to information on where you can find more jobs. Or where you can find these jobs. And Brian, we're obviously going to be linking folks to the campaign and some of these other things we're going to be talking about today. And my point is, if any of the folks on here today are thinking about that career change, or they know somebody who's going into the career field for the first time, we're going to follow up and give you a lot of that information. Rachel, let's turn to you for a minute. You represent a network of community health centers throughout the state that provide primary care, but also other specialty care. Now, you've been doing this really creative on-the-job training program with some state funds. Can you tell us a little bit about the program? How does it work? And in what ways is it making a difference? And Jackie, if you don't mind, I think there's a link we have to share about that. Oh, perfect. You're on it.
Absolutely. Yeah, absolutely. Thank you, Robin. Happy to be here today. I want to uplift that the MPCA, we're the member organization for Michigan's 40 community health centers, also known as federally qualified health centers, as well as 4 tribal health centers. And our members provide care to over 715,000 Michiganders, many of whom are low income, uninsured, underinsured, or on Medicaid. And certainly, as Brian touched on, healthcare was not immune at all to the workforce and labor challenges that the pandemic brought on. And as a result of that, we created the Health Center Careers Training Program. So in this program, students are employees of the health center, and they receive education and training at that health center while they are also receiving an income and benefits. So this program really offers a low barrier entry point for individuals who would like to enter the healthcare workforce as well as for health centers to take part in offering paid education training, on-the-job training opportunities. An added benefit to this program that has been wonderful to see, many of our members have been able to diversify their workforce. They through this program by realizing and reflecting upon what their current workforce looks like, and does that really mirror the populations and the communities in which they serve. So many of our members have been able to hire patients and bring them into their workforce, hire other community members and bring them on board. And so beyond just being a education training program, this program has really proven to also be a driver of economic development and opportunity right in the communities in which the health centers serve.
And I love the program too. I love the idea of the program because, I think so many young people, and not just young people, but I mean, anybody who's looking at a career change, it's daunting because you're thinking, well, I'm going to have to stop my own job. I'm going to have to put my own paycheck on hold, or at the very least, I'm going to have to add all these hours. I'm going to have to study, and I'm going to have a tuition cost. And this takes care of all of those things because it gives you may have, let's say, a receptionist who's now training, and tell me, Rachel, if I'm wrong, you may have a receptionist who's now training to be a medical assistant, and they're still working as they're working at kind of both jobs, and they're getting trained on site. It takes care of that tuition, and it gives you what you need.
Absolutely. No student loan debt. Providing opportunities to individuals that maybe have never had those opportunities presented to them for whatever barriers may have been present. We have health centers that have brought stay-at-home parents back into the workforce, that have really reflected upon their communities and identified individuals that they feel would be great employees at the health center, but who would also reflect their community.
I love the woman that we spoke, one of the women that we spoke to for that story. I mean, she said she would never thought about working around blood. It turned her stomach. But she thought she might give it a try, and she had just been among the first cohort to graduate as a medical assistant. She had never considered really a job in healthcare before. So intriguing stuff. Rachel, could you follow up with you? There's a state grant that supports this. This is not, obviously, nothing comes for free. Tell us how this whole thing is financed.
Absolutely. So we initially started this program with some seed funding from 2 of our Medicaid health plan partners. And shortly thereafter, we were awarded funding from the Michigan Department of Health and Human Services. So they invested $7.6 million into this program. And that was part of the larger $300 million investment that was made for healthcare workforce. And so that funding from MDHHS really fundamentally changed the program. It allowed us to help our members launch this program, and it has certainly helped our members be able to recruit, train, educate, retain those employees, and help them, again, grow jobs, be drivers of economic development within their own communities.
Michelle, I don't want you to feel ignored there. I've been using throughout our stories that when we're, these stories about healthcare workers shortages, we've been working with you on some of your really interesting data. And if folks haven't seen the workforce index, the worker index, I probably garbled that. It really is an intriguing toy to play with. And I say that, I don't mean to sound flippant, but it really does give you a sense of numbers here. So tell us a little bit about the index you created, why you took it on, and what does it show?
Yeah, of course.
And I'm sorry, I should mention again, you're with the Michigan Health Council that does a whole lot of research. It's been really interesting to follow over the years.
Yeah, so the Michigan Health Council is a solutions-oriented nonprofit with a 7-decade track record in sustainable programming for workforce development officials, state officials, educators, people, employers, all of those individuals. And we were really excited to do the Michigan Healthcare Workforce Index, or MHWI is what we've been calling it, or just the index, if you feel like being really short about it. And we took it on largely because, there's all of this conversation surrounding the health of our professions, but there hasn't been a lot of, I think, comprehensive data looking at where certain professions are in comparison to each other, but just also, overall, like, what are the wages for these individual occupations? And how has that changed over the last 10 years? How has the population of individuals working in these occupations changed over the last 10 years? What does it look like for the next 10 years? What turnover are they experiencing? And how many people are we producing, and is it really enough, right? So we wanted to take all of those different sort of facets, different pieces of data, and combine them together to get a comprehensive ranking of all of the healthcare occupations in Michigan to sort of determine which occupations are the healthiest and which occupations are the unhealthiest. And I put air quotes around that, right? Because the purpose of the report was really not to compare one occupation to another or to say that one occupation is X% better than another occupation, but rather to give you sort of a full picture of where occupations stand right now in the year 2023 in Michigan. And so even if an occupation is healthy, there are still challenges associated with that occupation. And even if an occupation is unhealthy, there are things that are getting better or positive sides to look at for that occupation. So it's not all doom and gloom, but it's not all rosy either, right? It was just supposed to be, how are we doing? Yep, go ahead. Did you have something?
Oh, no, go ahead. Go ahead.
Okay. So with that being said, we took a look at 36 different healthcare occupations in Michigan. And we ranked them on 4 different values. Shortage, which was, how many people are we producing compared to how many people we are expected to need over the next 10 years and what that difference is. Turnover, self-explanatory. Wage growth over the last 10 years. And then also the growth of the occupation expected over the next 10 years. And when I say growth of an occupation, I mean beyond just replacing individuals who are retiring, but rather how much is the occupation expanding to fit additional needs of the population of Michigan overall. And that could be because we have, our population is aging, so we're going to need more home health care workers in the next 10 years, that kind of thing, right? So we ranked all 36 occupations on all 4 of those input variables, and we came up with a list or an index. And so some of the more, I think, interesting results that we found, the healthiest occupation over the next 10 years is nurse practitioner. The unhealthiest occupation is dental assistant. Nearly all occupations are projected to experience workforce shortages between now and 2032. Even those occupations that are not expected to have shortages, there were a handful of occupations that weren't projected to have shortages, really still do have distribution problems around the state, especially when it comes to like rural versus urban areas. A lot of rural areas in the state where there just aren't enough individuals working in those particular careers. And then occupations with fewer educational requirements, typically anything that requires less than a bachelor's degree, and even in some cases less than an associate's degree, really struggled to break out of the bottom third of the index, largely due to the fact that the wages were so low that even if that occupation was growing, the low wages and the low wage growth that they've experienced over 10 years, they can't break out of the bottom third of the index. So that's a really big driver when we're talking about unhealthy occupations. And then I think finally, and maybe definitely not least, but last but not least, is that mental health occupations ranging from community health workers to psychologists really face immense shortages and competitive wage challenges. And that really, I think, raises concerns about like the health of our population over the next 10 years, right? Like making sure that we have enough mental health professionals over the next 10 years.
Whoops, there we go. I lost my mute button. Michelle, give us a sense really fast. I want folks who aren't looking at this index to get a sense of just the how many people we're talking about. Do you have your index right up front or right in front of you? Give us a sense of, for example, I was intrigued by the home healthcare aides. And I know it was one of the most needed, though dental assistance was most needed. That to me isn't a phenomenal number. These are folks who help us age in our homes, not go to nursing homes. They are people who help people with workers that help people with developmental disabilities. These are critical workers. How many do we need over the next 10 years, Michelle?
Sure. So when we're talking about change over the next 10 years, or how much the occupation is expected to grow over the next 10 years, we're saying that between now and 2032, and I use 2020, I mean, I know it's 2023, but just, I guess, for everybody on the call, the data was 2022 data because obviously this year is not yet complete. So we found that there was really about 18,000 individuals. That's how much the home healthcare aid population was expected to grow over the next 10 years, or 19%. And then when we talk about like whether or not that was going to be what kind of shortage that looks like, we're saying that we need a certain number, like the occupation is going to grow by a certain amount, in this case 18,000, but that on top of the population that already exists, and when you take into account how many people are completing certifications in this role, we're saying that the shortage over the next 10 years for home healthcare aides is close to 170,000 individuals.
And that's a lot because of the turnover. That's one of those
Yes.
jobs where you just can't keep people
Exactly.
in the job.
Exactly.
Which, interestingly enough, leads to the next question. And Diane just mentioned it. This is where we were going to turn next. Michelle, I'll start with you. Let's talk about some of the solutions here. We know about these numbers.
Absolutely. So one of the things that we talk about in the index, or I think there are really two big solutions that we talk about in the index. The first is this idea of more stepped or pipelines when it comes to healthcare careers. There are a lot of occupations, especially those that require less than an associate's degree, and in some cases less than a bachelor's degree, where there isn't a lot of opportunity for growth within the occupation once you've taken on that role. So you start out as a dental assistant, but what happens next, right? You work 3 or 4 years as a dental assistant, but then where do you go from there? And so I think there needs to be more discussion around this idea of building pipelines and building on-the-job training into these occupations, so that if somebody takes on a role that doesn't require as much education, they still have opportunities for growth in their career and the opportunity to advance with more skills, more knowledge, more abilities that allow them to then make more money, because you're seeing so much turnover in these occupations because they're not sustainable ways of life for people. When an occupation can make 45% less than the median wage of Michigan, which is $22, how are you supposed to live on that, right? Like, how do you create a good middle class life with that kind of wage? So I think that's the first thing, is talking about stepped opportunities for individuals in these careers. And then I think the second thing I would add is more CTE when it comes to high school students. Healthcare careers are not only competing within each other, but really within the entire economy, right? And so,
I'm sorry, CTE, explain that for people.
Career training education. So the idea that you could do some sort of career training while you're in high school, and then when you've finished high school, you're able to start in that role immediately without necessarily having to go through any other like post-secondary training. It's really common in a lot of skilled trades occupations. And I say that specifically because I think that that's where a lot of the competition for some of these roles lie. A lot of skilled trades occupations that you can do career training education for in high school, and don't require any additional training after high school. You do your training as a 16 or a 17-year-old. You don't take on any debt. You start as an 18-year-old, like as a third shift operator, and you make $25 an hour. How do you compare that to somebody as a nursing assistant who's making $17 an hour and probably wasn't able to do their training when they were a 16 or a 17-year-old because there isn't as much prevalence surrounding CTE programs for healthcare careers. So those would be the two, I think, solutions that we really discussed in the index.
I have to stop muting myself. Brian, let's turn to you for a minute about solutions. And I'm gonna pull in one of the questions from one of the readers about the $300 million for the workforce, because most of that did go to the hospitals, correct? Can we talk about, one, does that include for behavioral health expenditures? And then what are you doing with that 300 as part of the solutions here?
Absolutely. And first off, great presentation by Michelle. Agree with everything she said about the upskilling in the healthcare workforce. That's going to be critically important. So as you mentioned, the Michigan Health and Hospital Association just last year was very successful in securing $225 million for hospital workforce. That was for recruitment and retention, including our behavioral health providers within the hospital and health system domain. And then with the new legislature earlier this year, we were successful in securing an additional $75 million for our hospital workforce, so a total of $300 million. Last year, there was also funding in the budget for the skilled nursing facility, long-term care community as well. And in fact, the MHA last fall did produce a report that we shared with the public, certainly a report back to the governor and the legislature on how we invested those resources. And it was really heartening to see how many of our hospitals and health systems throughout the state put that money to good use. First off, we had to stem the tide in terms of those who were leaving the healthcare field altogether, and certainly leaving hospitals. We had to keep them. That was job number one, was to stem the bleeding. And job number two, of course, is this outreach to bring in new people. And that's the MI Hospital Careers effort that we discussed earlier. So we've done a lot in terms of funding, more to come in that regard. But when you talk about public policy solutions, we have long advocated for Michigan to become a member of the Multi-State Nurse Licensure Compact. We think that is good public policy. Most of the other states are part of that compact already. It would give it a much easier opportunity for our hospitals and others to bring nurses here from other states who are ready, willing, and able to relocate. Certainly, we need to look at immigration policy, and that's a matter at the federal level. That's something we've been advocating with our congressional delegation for a number of years. During the pandemic, we had major Michigan hospital systems that had nurses from other countries who were English speaking, fully trained, ready, willing, and able to fill those needs in Michigan hospitals. But to jump through all of the immigration hoops, it simply wasn't practical to do that in any meaningful number. And so we know that those are two issues that we have to look at. I'm a big believer in technology as a force multiplier, not a replacement, but a force multiplier for our healthcare workforce. I think you look at virtual nursing programs, you look at some of the promise, the upside of AI, artificial intelligence. Certainly there's downsides and concerns there as well. But I think on the whole, technology can really help to extend the ability of our workforce to do what needs to be done to care for patients.
One of the fun stories I did this year in this larger topic of worker shortages was to follow a robot, and folks of a certain age will remember Rosie from the Jetsons. And it was her name, his name is Moxie. And the whole idea is that this robot can cruise through the hallways and help nurses fetch medications, help nurses fetch lunches for patients. The whole idea being it is a bit of technology. To me, it was really fun technology to watch this robot cruising through the hospital system to help nurses, as you said, kind of to help what's there, not to replace the nurses, but to help them out. What did you say? Force multiplier, right?
Force multiplier, absolutely.
Force multiplier. So let's talk, let me talk a little more about immigration. And then we've had a couple of questions about folks with criminal backgrounds or with a police record, and them being, basically not allowed to train for some of these jobs that we so desperately need. So can we talk a little more about those two groups? I hear what you're saying. We need to address public policy. How do we do it?
Well, really, this is one of those issues in terms of immigration reform and in terms of the population that you mentioned as well, those who have a criminal record, where the politics of the day, whether you're talking about Lansing, Michigan or Washington, D.C., become very heated very quickly. And we understand that. But what we have lifted up is, at the end of the day, we are desperately in need of providers of care who can help all of us at our time of need, whether it's a friend, a family member, a loved one who needs health care. Let's do everything we possibly can to get qualified people trained and up and running in hospitals and other settings of care. Now, while the Michigan Health and Hospital Association has not taken a formal public position on the question of those with a criminal background, we certainly think it is appropriate for our elected officials to look at every single tool in the toolbox. And if there's a way to create the appropriate safeguards and to move forward in that domain, I think it's a population that we could tap in a very positive way. That's my perspective. And I think we need to look at every single opportunity at this point.
It certainly seems like there's such a variety of jobs, such a wide range of jobs in healthcare. There would be places for some of these populations. I talked to somebody the other day who was saying, he had heard of folks who had come over, now I'm going to the immigration issue, folks who had escaped from war-torn countries elsewhere, and they were surgeons, doctors, nurses, healthcare workers, and it was so much easier for them to drive a Lyft or deliver meals here instead of, maybe they can't be a surgeon right away, but doing some of those, the phlebotomists, the medical assistants, some of those jobs that we need.
Yeah, and I'll tell you, one of the very desperately needed roles that we haven't talked about at all is medical transportation. So it's something as simple as transporting a patient from a home to a clinic, or from the hospital to a skilled nursing facility, or to a rehabilitation facility. We have patients who are backlogged in a hospital well after they are medically cleared for discharge to another setting, who are there for days because we lack the available medical transport. And so that's another aspect of this domain. If you can drive a car, you can drive a truck and go through the necessary steps, we have an opportunity there as well.
And thank you, Drew. I just saw you put in the chat for me. I couldn't recall the name right offhand, but yeah, the group is Global Detroit. And they're working with folks who have just immigrated here to try to get them into healthcare. Again, what a huge amount of expertise and talent that's being wasted. If we don't pull them. Yeah, go ahead.
Rob, I just wanted to highlight that, I think our refugee population in Michigan, that is another population certainly that, we could do better work and bringing them into, the healthcare workforce. I personally know individuals who were, dentists, physicians in other countries and, come here to the United States, either through traditional immigration channels or as refugees, and they are not able to continue in those roles. And so many of our community health centers are a hub for refugee populations to receive care there at those health centers. And so that's another area of opportunity, another population that we could certainly explore bringing into the workforce.
Sure, absolutely. Let's talk, when we're talking about upskilling people, this whole idea of like offering them, kind of the career ladder. And I hear what you're saying, Michelle. Some jobs you kind of hit kind of an end point. Let's talk about creative ways to do more of that upskilling. And Drew, I think you had mentioned there are some states that are doing career counseling beyond career counseling. And helping people hit those extra points. Is there some other way we can help people get to that next step? And I don't know if that's more, Brian, we're all working, or your hospitals are working so much with the community health or community colleges. Are there other ways to help people get to that next step or even think about that next step?
Well, my perspective is we need to start at a very, very young age, because as someone who has teenagers myself, and I've lived through these last number of years where you understand where their influences come from and what they're exposed to on a daily basis. And certainly social media is more impactful than it's ever been. For young people. But if they don't have healthcare on their radar screen at a young age, it's very, very difficult to get their attention further down the road when you get closer to thinking about college applications and where you're going to go from there. So, my own perspective is we got to be really innovative, and we have to talk to young people too. We can't think that we have all the answers to this question. We have to talk to people like my teenage children and their peers. What's impactful to you, and what's the best way to message you?
Mm-hmm. Yeah, and I think too often when we're talking to kiddos, we tend to say, "What do you want to grow and what do you want to do when you grow up? You want to be a doctor or a nurse?" And we don't talk about these other thousands of roles there are that they're just not thinking about until way too far down the road.
Yeah, and I'll tell you, I mean, again, back to technology. It's perhaps an oversimplification, but I do believe there's a lot of truth to the fact that our young people today are more tuned in to technology. They believe that technology is the future, that that's a great place to land in terms of a career path. Well, if that's the case, I don't think there's any sector of our entire economy that's going to be more significantly impacted by emerging technology than healthcare. And so if you want to engage in cutting edge, whether that's the delivery of care, whether that's in the supply chain, information management systems, you name it, healthcare is the place to be.
I would just add,
yeah,
anecdotally, kind of expanding on what Brian said, getting to people at such a young age is really key. My sister is a pharmacist, an emergency room pharmacist at a hospital in Detroit. And while there's no like traditional upskilling path between becoming a pharmacy technician and then becoming a pharmacist, you can't just do enough work as a pharmacy tech to end up as a pharmacist itself. My sister started working as a pharmacy technician when she was 15 or 16 years old, and then got really interested in the idea of becoming a pharmacist. So I think that there's a lot of opportunity surrounding this idea of getting to people at a young age in some of those occupations that require a bit less education, and then hopefully encouraging them to pursue some of these levels of education once they graduate from high school.
Did I hear you right? She was a pharmacy tech at 15?
16.
Or 16?
16.
That's really interesting, because I think a lot of times when we're trying to help our teenagers get those summer jobs, it's about, do you want to run a smoothie machine or flip a burger?
Yeah.
Or maybe bag groceries. So flipping that conversation is probably pretty critical. Is there, Rachel or Michelle, I don't know if maybe one of you could answer this, because you've done so much of the look at kind of, well, I guess Brian too, rural versus, the differences between rural areas and urban areas. Are there certain jobs? And I will tell you this, I'm going to interrupt myself again. We always hear the statistic, there are not enough child psychiatrists in Upper Michigan and the UP. But that's, there are so many other jobs. What are the differences with the rural and urban needs?
Sure, I can start, then maybe Rachel can jump in. At least as far as the index goes, one of the things that we found is a lot of dental professions in particular. There are enough dentists in Michigan, but they're not distributed well at all. I would say if you're like north of Mount Pleasant, and in particular the Upper Peninsula, there are a handful of counties with maybe only one dentist per county, which is not where you want to be. Certainly that puts a huge strain on that person providing those services to have to be on call all the time or be available all the time. But it also is just like a huge strain on the population too, right? Like then people are not taking care of their oral health, and it becomes like a problem, a public health problem, possibly overall. So as far as like what we've seen in our data, and dentist is just, the example that I had off the top of my head, but there's a lot of other occupations like that. Behavioral health is certainly one of them, where the distribution of individuals is not in sync with the size of the population or where people are living. And so it certainly puts a huge strain on the system.
Sure.
Absolutely. Yeah, I echo Michelle's comments. And, one of the things pointed out in the index was the lack of, if we're talking about dental oral health, lack of dental hygiene programs in northern Michigan. And so one of the challenges that we do see, especially for our community health centers located in rural communities, is that if there aren't those academic training institutions located in those communities or accessible for students in those communities, then they have to, if you are a student interested in dental hygiene, for example, you need to leave that community in order to go train wherever that program is. And then we know just by research that there's, whether it's physicians or dentists or other professions, that there's a small likelihood that they're going to actually return to the communities where they're from. They're going to stay where they train. That's generally what the research shows. So many of our rural communities do struggle with that on a recruitment front, retention front. They need just as many healthcare professionals as anyone else. But when you don't have that easy access to those academic training programs and institutions, it makes it much more complicated.
Yeah, when it comes to rural, the backdrop here, of course, is that for many years, rural Michigan, generally speaking, is older, sicker, and poorer than the rest of the state. And so you have that challenge right out of the gates. And then you look at a situation when it comes to recruitment, particularly physician recruitment to rural Michigan. Bear in mind that in many occasions, when you're recruiting someone to come to a hospital, you are not only recruiting for the individual, you're recruiting for their spouse or partner as well. In other words, they have to find a job. Otherwise, they're not going to relocate to the community. Well, that's easier to do in a larger setting where there's more jobs outside of healthcare, perhaps. In a rural community, that recruitment effort becomes that much more difficult. And to really pick up on something Michelle mentioned earlier about the lack of behavioral health professionals, just to put a very fine point on this from a rural perspective, right now today, we have exactly one licensed pediatric psychiatrist in the entire Upper Peninsula. That is a incredibly challenging situation that we have, and it really points out the particular challenge we have in rural Michigan.
Well, and it's come up several times this last year as I've been doing these stories. Certainly you can argue there is a shortage of doctors, yes, but the bigger issue in Michigan, and remember, we have a lot of medical schools in Michigan. We do have a decent number of residency slots. The problem isn't so much total numbers; it's this maldistribution. To all of your points, trying to get folks into those rural areas. Let's talk a minute about one of the, and I'm turning to some of the reader questions right now. At some point, and I remember this as well, it seemed like most nurses had to have their BSNs to work as nurses, or at least be on that road to getting a BSN. One of the readers asks whether or not, hiring nurses that have less than that BSN, does that affect qualities? Does that affect care? Should we be concerned about that?
My perspective is, and we talk with our hospital and health system leaders on a daily basis, they really entrust their chief nursing officers, the CNOs, who have the experience, the background, the training, and quite frankly, the window into the big picture, meaning they're the ones who wake up every day and see all of the metrics. They know what the acuity level of their patients will be on that particular day, that week. They know the training of their nursing staff, but also all of the other members of the care delivery team, because let's remember that nothing happens in a vacuum. Certainly, they know about the technology that the hospital may or may not have available to deploy. They know about seasonality in some of our tourist areas. They know about the difference between a Saturday night versus a Wednesday afternoon. They know, and it is their responsibility to staff appropriately. And that goes for the people that they're hiring as well. Now, sometimes the realities of what's available on the market, as we've all been talking about this afternoon, come into play. But they are doing everything they possibly can to create the safest possible environment, starting with the team that they're recruiting and retaining. And we at the Hospital Association, we're doing everything we possibly can to support that effort and to collect the data about quality of care through the MHA Keystone Center, for example. Over the last 20 years, we have a wealth of great data, great information about how quality of care here in Michigan hospitals has played out.
Again, the Keystone Center being the place that's collecting all this data from all these different hospitals to figure out best practices, what's working, what's not. Okay. right in the middle of the pandemic, and I think I've mentioned this to all three of you, but, and I say it often, I had a friend who was in her mid-50s and became a nurse in her mid-50s, having helped her daughter train or get ready for the NCLEX, and she thought, I can do this too. So it's always intriguing to me, the people who are doing mid-career changes into healthcare. Let's elephant in the room. Why don't we just pay people more? Give them an extra $5 an hour. Tell me why that seems to be the problem. Why can't we pay them more than McDonald's wages? Not to pick on McDonald's.
Man, if I had the answer to that, I don't know that I would be sitting here. I would probably be on an island somewhere because we would have solved all the world's problems. I mean, I don't know. I agree with that statement. I'm not sure why. Especially when you're talking about the wage competition from not those other occupations we were talking about before, a lot of skilled trade occupations, which require similar amounts of education and investment, but make a significantly higher wage, right? At least above the median wage. So yeah, I wish I had the answer to that question.
Yeah.
So Robin, it's a great question. And the reality is, whether you're talking about our nurses or anyone else working in today's healthcare system, they have an incredibly challenging and complex job, and they deserve to be well compensated. There's no question. But I think we have to step back and think about the reality of the healthcare econometric model, which is just different from the rest of the economy. I'll take hospitals as a perfect example. In business school lexicon, we are the classic price takers when it comes to two of our biggest payers, that being Medicare and Medicaid. We don't get to dictate what the price tag is for the services that we deliver. They tell us, here's what we're going to pay you. And oh, by the way, for years, it has not met the true cost of care. And then when it comes to private insurers, which cover much of the Michigan population, I can't remember the last time I walked into a meeting with anyone from the insurance sector where they said, what we're hearing from our patients and our customers, the businesses that we serve, is we really think we need to pay you more. So let us do that. In fact, the opposite is true. Everyone believes that healthcare is too expensive, and there's incredible pressure on the insurance companies and others to keep those costs in check. And so what I'm saying is resources become increasingly scarce on a relative basis for those trying to run hospitals or frankly any other healthcare enterprise. And so I think you have to start there in order to answer the question that you posed. But at the end of the day, no question. I mean, the people doing the work of care delivery deserve to be well compensated. And I think we're trying everything we can to make sure that happens. That was the $300 million that we referenced earlier. That's what the MHA went out and secured for exactly that reason, to try to address some of that cost.
And if I can add to that, I mean, absolutely, to Brian's comments, we encourage our health centers to pay at minimum a living wage. So they use and we encourage the use of the MIT living wage calculator. So, ensure that you are at least paying your employees a living wage. They certainly all deserve to be paid, a competitive wage to other sectors. But, as well, to Brian's point, one of the challenges is the reimbursement rates, especially with health centers, the Medicaid reimbursement rates. They do not cover the true cost of care that our health centers provide. Our health centers on average right now are losing about $60 per Medicaid patient for every visit. And so, and that number I think is actually increasing. And so it is a challenge with reimbursement. If the reimbursement is not there, then it is very difficult to find the funds to be able to raise those wages. It's just, unfortunately, that's the economic look when it comes to healthcare and to the reimbursement.
Brian, I think I've heard you say it a couple of times. It's not like you're running a restaurant and can raise the price of your hamburger. You're kind of stuck at the money that's coming in. Yeah.
So one last thing to add on that though,
Yeah.
positive Medicaid reimbursement. We have been very encouraged to see reimbursement now available through Medicaid for doulas, as well as upcoming for community health workers. And that has had a direct impact on health centers being able to grow their workforce. We now have health centers that have brought back doula programs, partnered with hospitals. We also have many health centers already employed community health workers, but are now bringing more community health workers into their workforce to serve patients because of that available reimbursement. So those are two great positive recent developments that we have seen.
Yeah, I'm really interested in writing about this community health workers. It's such an intriguing job for somebody who wants to work in health and doesn't want to be around needles, but wants to help solve health problems and address social determinants and whatnot. And I want to make, I'm going to try and bring some positivity to this too, or some positive news to this too. You know, Michelle, we were talking last week, excuse me. And Brian, you mentioned the transportation issue. We did a story not too long ago about the lack of EMTs and paramedics, this desperate need for them. And so on the very downside, I mean, talk about sobering. We looked at the EMT wages, Michelle, you and I, and how much they have not changed in 10 years. That's terrible. And I literally sat in my office, did a quick search, and found that the a half mile away, that McDonald's was paying more for 2 new staff positions than you could get paid as an EMT. That's terrible. On the other hand, paramedics have seen quite the wage increase over 10 years. So there are bright spaces here too, right?
Definitely. I would also say that some of that may also be related to a shift in what ambulatory care services are looking for. This is only anecdotal. I haven't done the legwork to back this up, but I have a handful of friends who are paramedics up north in Antrim County and Charlevoix County, and they all, like, in order to get their jobs, had to become paramedics. There just wasn't a lot of opportunity available for EMTs, at least in that area at that time. I don't know, like I said, I haven't done the appropriate legwork to know if this is a universal situation, but I wouldn't be surprised to see that there may be more of a draw for paramedics in ambulatory care services than EMTs, just because they can do more on the job than an EMT can do in the case, you know, of an ambulance call. So it could be that we're just seeing a shift in what employers are looking for.
Yeah, interesting. I'm going to take I think we have time for another reader question. Somebody asked about, you know, the shorter hospital stays. And I think, Brian, this is obviously a question for you. The shorter hospital stays and shifting recovery care from within facilities into home. You know, essentially sending folks home sooner than they might think they're ready. Is there some kind of program? Is there some kind of plan to help better train families so they can kind of fill in for this healthcare worker shortage in the recovery?
So the reality is that there may be instances in a certain geography or a certain organization where average length of stay has declined. We're a big state with 134 hospitals, so there's always exceptions to the rule. But here at the MHA, we do collect data on all of our hospitals. And the reality is, since the pandemic, the average length of stay in our hospitals is actually on the rise. And it's on the rise for a couple of reasons. One of the reasons has to do with the fact that there's been so much pent-up demand for healthcare. These are the people who probably needed to come into the hospital for a relatively minor procedure or screening, but were fearful to do that during the darkest days of the pandemic, which we all understand. But then their condition worsened to the point where now that average length of stay is a bit longer than it might have been previously. And then the second reason why length of stay is on the rise has nothing to do with the the clinical condition of those patients or the acuity level. It has to do with this workforce issue that we've been talking about, meaning, as I mentioned earlier, we have folks who are still in the hospital a day or two or three after they're ready for discharge because of the transportation challenge, or they need to be discharged to a behavioral health inpatient facility or to a skilled nursing facility or a rehab center or something of that nature. And guess what? There's no room at the inn. There's no place within a reasonable geography where they can be discharged to. And so what happens typically is those patients stay in the hospital, oftentimes boarded in a hallway. As terrible as that sounds, we have no other option at some situations. And in some cases, they get discharged to the home, perhaps before that's ideal. And so we're trying to get our arms around this issue, but certainly working with our members every single day to find the appropriate solutions.
Well, before we start talking about mental health care, which is a whole nother lunchtime discussion and more, I'm going to turn this back over then. I think, Jackie, I think we're going to close. And I do want to thank everyone personally, the three of you. Thank you for taking time. I know from my talks with you before, you're all very, very busy people. So I appreciate you taking the time and appreciate the readers for joining us. And readers, please do watch out for your email. We will follow up with a lot of really helpful links for you. Jackie?
Thanks, Robin. Thank you all so much. That's okay. Thanks so much to all of you for being here, Robin, for moderating. To our special guests, especially Rachel, Michelle, Brian, thank you so much for sharing your expertise and your knowledge with all of us today. And thank you to all of you who joined us today. You had some really great questions. And as Robin said, we're going to follow up via email so that we can share a whole bunch of information about some of these programs we discussed today to help bolster this workforce. A reminder that we did record today's discussion. So you will see a recording on the Bridge Michigan website later this week. So if you'd like to watch again, or if you know someone who could really benefit from learning more about what we discussed today, you can feel free to share that recording with them, and we'd really appreciate it. Our next lunch break event will be held in September, and an announcement about the date, time, as well as topic will be coming very soon on our website, bridgemi.com. Thank you again so much for joining us on this late summer day. We really appreciate it, and we hope to talk with you again soon. Have a great afternoon. Take care. Bye-bye.